Hello, and welcome to our series on using proficiency testing data to improve the performance of your molecular laboratory. My name is Valentina Nardi from Massachusetts General Hospital and Brigham and Women's Hospitals in Boston. And the topic of today's series is common laboratory errors in next-generation sequencing assays. These are my disclosures. And so let's start with a clinical vignette. We have an oncologist who comes to you because his patient with lung cancer reportedly had been found to have a KRAS G12C mutation at an outside laboratory, but your laboratory detected a different KRAS mutation upon repeat testing. How do you reconcile the results? And so this is going to be one of the most common errors in next generation sequencing testing that we will review today. So the bottom line up front is that laboratory errors in NGS PT surveys are overall really uncommon. Laboratories perform really well. And this is also highlighted in a more recent publication from the same molecular oncology committee from the CAP, demonstrating very good performance in detecting KRAS and NRAS mutation by laboratories. So what are the most common errors? How could they be avoided? Well, they could be avoided by optimizing informatic pipelines, by manual review of results, and by using the correct mutation nomenclature. So what is in the size of the problem? As we said, fortunately, is very small. Based on somatic PT surveys, the accuracy was around 96% between 2016 and 2019. And based on germline PT surveys, the accuracy was close to 98% between 2015 and 2019. And the most common errors fall in two main categories. The first one is analytical errors, and these include false negative errors, false positive errors, and errors in annotation. And then the second category are non-analytic errors. So in terms of analytical errors, let's look at false negative errors. Those usually occur when variants are in difficult to sequence regions. For example, regions with very high GC content. Classical example would be for variants in CBP alpha. CBP alpha is a commonly mutated gene in hematological malignancies, is an intron-less gene that is over 75% GC rich, as you can see also in the picture here. And so when laboratories were challenged with a CBP alpha mutation, the C68-DUP-C, about 28% reported false negative results over 3 different surveys. And the VAF for this mutation was pretty high, between 29 and 50%. If we look at false positive errors, those tend to occur for variants in homopolymer regions. Those are regions where there is a repeat of the same nucleotide. And so again, really good examples are for ASXL1 that has a homopolymer region, and actually the most common pathogenic variant in ASXL1 is this 1934 DUP-G that occurs in a homopolymer region. And so in 2018, about 7% of laboratory had a false positive result as they reported out this variant when it was not supposed to be there. But fortunately, this error rate dropped to 1.3% in 2019. And the variant allele frequency for this variant was between 4% and 14.5%. And so, for example, in my laboratory in the past with a prior NGS assay that we used, we detected this ASXL1 mutation in every single specimen that we ran. But we saw a bimodal distribution, if you look at the graph here, whereby when it was an artifact, it was detected at very low allele frequency, usually less than 5% or even less than 3%. And then when it was actually a pathogenic variant, a real variant in the sample, it was detected at much higher allele frequency. So really with a bimodal type distribution. And finally, the third type of analytical errors are errors in annotation. These occur for multi-nucleotide variants or duplicating insertions. And so a substitution is a change from just one nucleotide into one other nucleotide. when there are 2 sequential nucleotide changes or 3 sequential nucleotide changes, so a dinucleotide change or a trinucleotide change, those are not considered substitution, but rather deletion insertion variants, so del-ins. So in these type of errors, laboratory detected a variant, but they annotated it incorrectly, which still is considered an error in proficiency testing. Most of the time, this may not have any clinical impact, but in the vignette I showed you, it actually does. And so an example of a dinucleotide variant is shown here in the image, where we have a KRAS dinucleotide variant, and the correct annotation is a del-ins variant. And so between 11.9 and 37.5 of laboratories did not correctly reported multinucleotide variants across multiple surveys. This is a table showing that different multinucleotide variants that laboratories were challenged with in CDKN2A, HRAS, KRAS, and NRAS. And then I highlighted here a column showing the number and percentage of laboratory that did miss the variant. So most laboratory will detect, or their pipelines will report just the first of the dinucleotide or trinucleotide variants. Other laboratories will report these dinucleotide or trinucleotide variants as separate single nucleotide variants. Going on to non-analytical errors, those could be pre or post-analytic errors due to either specimen swaps or transcription errors. Fortunately, they are uncommon, but between 0 and 2% of surveys have this type of errors. And so how could laboratory mitigate false positive and false negative errors in their NGS assays? Well, if we look at the detection of variants in genomic region with high GC content that they are difficult to sequence, laboratories could include DMSO at 2.5 to 5% or betaine, or include a heat denaturation step, or eventually consider an orthogonal method. In terms of improving detection of variants from homopolymer regions and avoiding false positive calls, using already a high fidelity DNA polymerase could mitigate this error, optimizing variant calling parameters to distinguish artifacts, and also using error correction methods like unique molecular identifiers. We didn't talk about false positive from pseudogene interference, although those have been seen in germline proficiency testing. And, these could be mitigated aligning to a different reference genome and considering maybe long-range PCR and Sanger sequencing. Then we talked about errors in reporting multinucleotide variants. Those are errors in annotation, not detection. And so it would be even sufficient to manually review the variants to notice that they are dinucleotide or trinucleotide variants that should be reported out as a deletion insertion variant, and then using the appropriate HGVS nomenclature. Similarly, we haven't talked about that, duplicating variants should be reported out as duplications, not as insertions. Again, it's not an error in detection, it's an error in annotation, but it will still be marked as an error in your proficiency testing results. So again, manual or bioinformatic review of the data could, raise a flag for an error from the pipeline incorrectly annotating the variant, and then the appropriate use of the HGVS nomenclature will mitigate the potential error. Also, laboratories should pay attention to the transcript use, which may differ from the one suggested in the proficiency testing reporting form. And then finally, in terms of pre or post-analytic errors, laboratories should conduct a critical analysis of all the potential steps that have led to that error. For example, they could have a second person checking every entry before the results of the PT are submitted. Of course, it's good practice to avoid having multiple patient specimen in active work area at the same time. Specimens should label one at a time before proceeding to the next one. A second person could check the labeling of the tubes. And then, of course, it's important to consider investigating potential sample swaps with molecular methods. So going back to the vignette where the oncologist is puzzled of why an outside laboratory detected an actionable KRAS G12C mutation, but your laboratory doesn't, how do you reconcile the results? And so here is a screenshot of the variant. Now we know that this is a multinucleotide variant, a dinucleotide variant. So probably the outside laboratory may not have manually reviewed the variant and realized that the annotation was incorrect. So we are looking again at an error in annotation, not in detection. So the reporting of this variant, it's incorrect as a 2 or 1 single nucleotide variants. It should be reported as a deletion insertion variants. And unfortunately, it is not the G12C mutation that the oncologist was hoping for. And so as we wrap up, I want to let you know that there is a molecular oncology topic center available on the College of American Pathology's website, cap.org. And the topic center is a repository of peer-reviewed publications and resources on the topic of molecular oncology testing, including some of the lessons learned from proficiency testing. Thank you.